Well, thank you for having me. I much appreciate the time and everybody being here. I'm sorry I'm not able to share my camera for some reason, but that's okay. So today we're going to shift gears from extreme venous work by Dr. Ranade to some of the cute little babies and pediatric vascular interventional work. So my talk is basically mostly based out of cases which I have done during my residency, fellowship, as well as my attending life. So I'm going to start right away. Pediatric IR versus adult VIR. So there's a saying that when people say anybody who has done an adult IR can basically do about 70 to 80% of the pediatric work. That's may or may not be true depending on how and what your training was. These are not just the little adults. There is a difference in physiology. There is a difference in anatomy. There is congenital problems. There's numerous concerns. The equipments are different. Stock supply issues because they're not designed for pediatric because the market is not big, although that's changing now. There is significantly increased monitoring and anesthesia needs. Most importantly, and if you can see here, it's highlighted, their staff needs to be comfortable monitoring this patient population. Believe me, you might be able to do it, but if your staff is not able to monitor or comfortably take care of the patient, you're not going to be given the privileges to do the cases. So this is a different disease process. There is many different variations involved. So don't just consider pediatric patients as little adults because they are very different. Again, the same thing. I think it's probably going to be the theme of the day. We work with every single specialty. Image guided, minimally invasive. We avoid larger incisions, less pain, traumatic, atraumatic, lower cost, collaborative. Complication rates are minimal. Less need for anesthesia. Although not in pediatric, we pretty much put everybody to sleep except for a few procedures. Diagnostic approach, adult world modality is the imaging is dependent on what the disease is. In pediatric world, the first answer is always ultrasound. Second and third answer is also ultrasound. Then goes to MRI and then maybe to CT. Again, it's because of avoiding the ionizing radiation, and that again, MRI may require anesthesia as well as CT, and therefore the increased risk, which is related to anesthesia. Day to day in peds VIR, you can do anything between vascular and non-vascular, and even some hybrid procedures, embolizations, sclerotherapies, laser photocoagulations, vascular anomalies, neurovascular angiography and interventions like vein of Galen malformations, retinoblastoma, chemoembolizations, AVMs, venous access, thrombolysis, lymphangiography, and in non-vascular, we'll do biopsies, drainages, accesses, tumor therapies, biliary pain. It just keeps going on and on. Now the field is expanding so much that there is significant need for peds IR. Radiation considerations, as everybody knows, it's ALARA, it's time distance shielding as low as reasonably achievable. And this hypothesis was actually based out of atomic bomb survivors. That was quite an interesting fact that I learned. There's a society for peds also, it's called SPIR, Society of Pediatric Interventional Radiology. 2006, there was a conversation. Now it's become quite big, and the last meeting was held in Ireland, and this year it's in Disney. Vascular access is the bane of existence for not just peds IR, but any pediatric patients. Again, these can be very difficult, especially if you're doing the upper extremity access. The access needles could be even a 24 gauge needle, which will accept an 010 and 008 wires. And there is now a slew of wires which come in smaller sizes like 40 centimeters and 60 centimeters. So you can always use that. We do offer bedside services for vascular access and drainages and maybe PCNs in very small kids who are sick and they're difficult to transport. So we'll perform these procedures at bedside with the help of ICU team giving sedation. Again, you see this 2 millimeter vessel in a kid. We basically have to consider that you cannot put more than 50 to 60% of the lumen you cannot occupy with the PIC. So there's therefore smaller sizes like 1.9 French single, 2.6 double, 3 French single, and 4 French dual, which is pretty much encompasses all of the vascular access that we do in kids. Biopsies, just like anybody, there is like soft tissues, bone biopsies, several bone biopsy devices. We do multiple passes because a lot of these end up going to research protocols for the cancer especially, and you don't want the kid to go under anesthesia again. There's many devices out there in the market, Bonopti, OnControl, Jamshidi. I also have now started using these bone biopsy devices, even for my cryoablation, as in like a Seldinger technique. There is another device in the market called Huntington Kit, which I use for accessing the bone and come out, leaving the K-wire in and using that as the Seldinger technique. I'll show some of the examples later. This was Dyna CT guided bone biopsy of C3. This came back as osteoblastoma. Enteric tubes, again, this is one of the other things that comes with the PEDS arena. Feeding intolerance, aspiration risk. Many patients who have congenital syndromes, they also have issues with feeding, so they end up getting gastrostomies, conversions. Many institutions utilize sedation. We mostly don't, and sometimes very high risk patients can go under anesthesia for these, but these are quick and sometimes very easy, but they can be extremely challenging in patients. Like, for example, I'm going to show one example after this slide. Some of the tips and tricks is use a short compy and a 20 cc syringe with half filled air and diluted contrast, which gives you options of both the worlds while live. And you may occasionally need to vent the stomach so that you can help reduce the size of the stomach to get post-caloric. This was a 32-year-old female, trisomy 21, has GJs for a long time. They keep falling up and they come back, and then we ended up doing, she had lost her GJ. We got back the access. We were unable to get in. Finally, we were able to get in, but you can see these many loops. Ended up diagnosing her with malrotation just because of we exchanged her GJ. So she ended up getting a treatment for that. Vascular malformations, switching gears. Lymphatic malformations, venous malformations, AVMs, capillary malformations, PAVA, which is a new entity, glomerulovenous malformations, many of the things that we can help with. This was the ISWA classification, which was last updated in 2018. I think they're coming up with the new one. This is International Society of Vascular Anomalies. You can go on their website. It's free to become a member, I think, and you can learn everything you need to know about it, because the terminology keeps changing every time and it becomes more and more specific to each disease process. Lymphatic malformations could be macro or microcystic. These are commonly found in the trunk, sometimes also in the extremities may transilluminate. These are microcystic, both may have cutaneous vesicles. I'm going to try to move faster a little bit. Lymphatic malformations look like cutaneous vesicles, but below there is a lymphatic malformation, which you can treat with sclerotherapy, as you can see here, and they become better over time. Venous malformations, these could be blue, purple, soft and compressible. They can typically increase in size with Valsalva and frequently have palpable thrombi. Diffuse could be genetic, focal could be somatic. They present with pain, and this could be affected site could be hypoplastic. In a kid where you can see there's this venous malformation, we got access into it. The treatment could also be just done under ultrasound, make sure not going into the central veins. Just like this snowstorm appearance is when you inject the sclerosants like STS. Fibroadipose vascular anomaly. It's a mesenchymal transfer malformation of fibrofatty tissues. They may interfere with muscular contractility, and they cause a lot of pain because they're encircling the nerves. And again, they present with pain. Conventional treatments have been regular treatments, and then cryoablation is shown to be effective treatment option in these. I'm going to try to move a little bit more faster because of time. So cryoablation, and here's the ice ball, and it was gone. Glomerulovenous malformation is similar to vascular venous malformations. It's just a different variety. AVM, nasal AVM, doing a direct stick, and it's gone. Biliary interventions in kids, sometimes they can have inspissated bile syndrome, which is where you have biliary cast because of ischemia, and then you can do normal saline flushes of the bile, of the getting access into the gallbladder, normal saline flush of the whole system, and can completely clean up the system. We did a poster on this, inspissated bile syndrome in neonates, did a bunch of cases. Transplant related work, like for example, this was iatrogenic but Chiari, and then we ended up doing a post-triple hepatic venous angioplasty, opening up all the 3 veins. Upper extremity swelling, compression syndromes, Paget Schroeder, do a thrombolysis, and don't ever place a stent on these ones. Again, some of the pictures, May Turner angioplasty. Again, there is still collateral, so we ended up stenting it. This is a mesogonadal shunt, which was thrombosed. It was after the thrombosed tips, patient underwent surgery to get a mesogonadal shunt, which also ended up getting thrombosed and presented with bleeding varices. We got direct stick into it and got access from above.
Allotted time for the presentation is now expired.
And then subsequently, we opened up after thrombectomy and angioplasty. I'm going to move forward a little bit with the last part of it, which is oncology. Here, the kid has multiple tumors in the liver, where we ended up treating one of them with microwave, the other one with Y90, and the adrenal met was treated with cryoablation, and her CEA level was 11.9. All right, I guess just that gives you an idea about a lot of things that we can offer in pediatric world. And if anybody is interested, this is just a list of things that we can do in pediatrics. Feel free to ask any questions, comments.